Hi, everyone. We'll just give it another minute just to let others jump on. So good evening, everyone, and welcome to tonight's Here to Help You Conceive webinar. My name's Lisa, and I will be your host. Just while everyone is settling in, I would just like to begin with an acknowledgement of country. In the spirit of reconciliation, Monash IVF acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. So, as I mentioned, my name's Lisa Collins, and I will be your host for this evening. I'm the team leader of the nurse inquiry team here at Monash IVF. I've worked as a fertility nurse for about 12 years and have been with Monash IVF for the vast majority of that time. I'm incredibly fortunate to work alongside an amazing group of nurses who are essentially here to answer all of your questions. It's a real privilege getting to speak with people every day, hearing their stories and discussing their options so they can make an informed decision about their fertility pathway. I will talk a bit more about the nurse inquiry team and how you can contact us a little later on. But just to let you know a little bit more about Monash IVF, Monash IVF provides world-leading scientific and medical services. We're committed to empowering the next generation of parents on their journey to parenthood. We're here for people at all stages of their fertility journey and are proud to support patients of all genders and sexualities on their pathway to parenthood. The entire Monash IVF team are incredibly passionate about the care and support we provide our patients. In terms of where you can find us, Monash IVF have clinics all across the country. So we're located in Victoria, New South Wales, Queensland and Western Australia. And we also have sister clinics in the Northern Territory and South Australia. Here is a look at the services we offer. Monash IVF provides comprehensive reproductive care. So we offer everything from fertility testing right through to IUI, IVF, ICSI and genetic testing. And of course, we can also support a variety of donor treatment options. Here's a quick look at the agenda for tonight's webinar. So the team will be sticking around at the end of the presentations to answer your questions. So if you do have a burning question that comes up while you're listening, please feel free to submit it using the Q&A button at the bottom of your screen. Before I introduce our presenters tonight, just a quick disclaimer. Whilst we will do our best to be affirming, we just want to flag that this webinar may include gendered language or medical terms. We know that not everyone identifies with these terms and that people may use different terms to describe themselves or their bodies. We're proud to support patients of all genders and sexualities. Everyone is most definitely welcome in our clinics. The information provided in this webinar is general in nature and does not replace personalised advice from medical professionals. So presenting for us this evening is Claire Byrne. Claire is a senior psychologist at Monash IVF and an endorsed counselling psychologist. With over 10 years of experience at Monash IVF, Claire has supported individuals, couples and groups through their assisted reproductive treatment journeys. Tonight, Claire will be discussing the support resources available at Monash IVF and sharing practical strategies to help build resilience and inner strength, preparing you for any challenges ahead. Our next presenter will be Dr. Gabrielle Desanos. Dr. Desanos is a certified subspecialist in reproductive endocrinology and infertility with over 20 years of experience. She specialises in fertility care and reproductive microsurgery, including vasectomy reversals. Tonight, Dr. Desanos will be discussing fertility treatment options, providing valuable insights into how she supports patients navigating their fertility journeys. And our final presenter will be Tegan Ekanyaki. Tegan is a senior embryologist at Monash IVF's new Cremorne site in Melbourne. She has over 7 years of experience, having worked in Australia and the UK. Tegan is committed to providing the best scientific care to patients during their fertility journey, whilst looking after their gametes and embryos. Tegan will be discussing the new fertility treatment options in the embryology labs, such as time-lapse incubators and piezo-ICSI, and we'll also highlight the latest success rates across Melbourne Monash IVF sites in Australia. So to kick things off tonight, I just want to start by giving just a bit of an overview on the first steps in the process. I think it's there's so much information online, and sometimes it can be confusing as to where to start. So essentially, the first step in the process is seeing your GP to obtain a referral letter to one of the Monash IVF specialists. If you're a couple, both of your names will need to be included on the referral letter. And your GP may take this opportunity to order some baseline fertility tests, depending on your situation. It's certainly not mandatory to have any testing done prior to seeing a Monash IVF specialist, but sometimes it can be helpful going into that initial appointment with some results. Following that, I would certainly encourage you to contact the Monash IVF Nurse Inquiry team for assistance to organise an appointment with a fertility specialist. So your GP may refer you to a specific specialist, or you may have an idea about which specialist you'd like to see. If you're not sure, though, the Nurse Inquiry team can certainly assist in setting you up with a specialist in your area that meets your needs. There are options for virtual consultations for regional patients, and some of our doctors also offer out-of-hour and weekend consultations. At the initial consultation with the fertility specialist, they will obviously discuss your medical and fertility history and run through any previous test results you've completed. There may be some additional tests recommended at this stage, depending on your circumstances. Doctors and designers will be talking us through the various fertility investigations later on this evening. But essentially, once the specialist has all the necessary information, they will talk you through the various treatment options and formulate a treatment plan with you. For some patients, counselling is a mandatory requirement prior to commencing fertility treatment. So for those of you who live in Victoria, counselling is required. If you live in other states and you're receiving donated eggs or sperm or donated embryos as part of your treatment, then counselling would also be needed. But once you've ticked all those boxes, then you'll be ready to commence your treatment. So how can the Nurse Inquiry team help? The Nurse Inquiry team are here to answer any questions you may have. So no matter where you're located around the country, we would love to hear from you. We do offer complimentary chats over the phone to provide you with personalised guidance on your next steps. So during a call with our team, we'll gather a little bit of background information to better understand your circumstances. This will include learning about where you live, your age, whether you're single or in a relationship. And additionally, we'll ask some details about your fertility history so that we can tailor our advice to your specific needs. So we can guide you through your next steps, help you determine whether it's the right time to consider some fertility testing, or whether it's a good point in time to consult with a specialist. We can discuss various treatment options and their associated costs, and outline any potential timelines for each approach. If you're ready at that point, as I said, we can also assist in scheduling appointments with our fertility specialists. I've just popped up a list of some of the frequently asked questions that we often get asked at the Nurse Inquiry team, but honestly, no question is off limits. We speak with people at all stages of their fertility pathway. So whether you're in the very early stages of family planning and just want some advice on tracking ovulation, or if you have been trying to conceive unsuccessfully for some time, we're more than happy to chat. So if you would like to arrange a complimentary, no obligation chat with one of our experienced fertility nurses, you can scan this QR code or contact us via the website. So you're probably all sick of the sound of my voice. So without further ado, I will hand over to our first presenter, Claire. Thanks, Claire.
Hi everyone, my name's Claire and I'm one of the senior psychologists here at Monash IVF. I'm down in Victoria at the moment, sitting on Boonwurrung country. Lovely to be here tonight, and thanks Lisa, and definitely not sick of your voice, that's for sure. Tonight, I guess I'm here to talk about the emotional support that Monash IVF can provide and that you might find that you need throughout treatment. In terms of the types of counselling we provide at Monash IVF, part of that is what we call pre-treatment counselling, and Lisa mentioned that before, and there are different requirements in different states. So sometimes we do this counselling before you start treatment. And we also offer supportive counselling throughout the journey as well. In terms of pre-treatment counselling, this is really, I guess, it's not therapeutic counselling like you're sitting on the couch like they do in the movies or anything like that. It's more what we call implications counselling. And so we're talking to people about their choices and decision making. We talk to people about the emotional and psychosocial impacts of treatment and the possible outcomes. So trying to think about those types of things. We talk to people sometimes about the relevant state legislations and any consent sort of requirements and things like that. We will talk about sort of expectation management, and we'll talk about general coping through treatment and how people can cope. And we'll talk a little bit about patient history as well, because of course their past experiences, of course, going to impact the way they experience the treatment process. So we'll talk about that and how they might best cope, and what the clinic can do to change things up and support people through that as well. Where treatment involves donation to eggs or sperm or embryos, we'll also talk about the impact on the donors and the recipients, their families and others. We'll talk about disclosure of the donor conception to children, family and others, the boundaries between the donors and the recipients and their expectations and things like that. And where treatment involves surrogacy, sort of more extensive counselling, this type of pre-treatment counselling is often required. And the counselling we're working with, the team is comprised of psychologists and social workers with specialised fertility knowledge as well. In terms of our support counselling, we do provide support counselling throughout the fertility journey. And so, people might need support throughout their journey just in terms of a wellbeing plan. They might need some assistance with decision making, or talking about their treatment options and those types of things. Some people might just need a place that they can feel open to vent and debrief and those sorts of things. And of course, whilst you're undertaking treatment, life can happen at the same time, and so you might be dealing with other issues that are kind of impacting treatment, and they're impacting those other issues as well. And sometimes people, might be considering whether to end treatment or move on to other different types of treatment and things like that. And so we can provide support around that process as well. Decision making, I guess, is a big one, and there's different stages of this for different people. It might be deciding whether or not to do treatment at all. It might be, differing views with a partner if you've got one. It might be some of the practical social considerations that you need to, I guess, weigh up and balance up. And so decision making is something that we're often talking about with patients, and that's definitely something that we can do in the counselling space. As well, we have, I guess, a lot of emotional considerations in the treatment process. It's really normal to feel anxious about starting IVF treatment and different types of treatments and the side effects of medications and what that's going to be like. And think a lot of people come as well with worry about the possible treatment outcomes. Where do we sort of sit? I guess we're trying to aim for this realistic hopefulness. We want to have realistic expectations, but of course we're not going to go through something like this without hope. Waiting for test results can be a really challenging time as well. And so, and this whole experience can feel quite isolating and things like that. So being able to talk to somebody who knows about that and can kind of normalize it and tell you about, everybody else's experience through this can be really helpful, I think. And resilience. I was here to talk about resilience tonight as well. And I guess, if we think about what resilience is the ability to bounce back when we face challenges in our lives, to bounce back when things don't go as planned or we'd hope. And I mean, fertility treatment, really definitely needs that resilience, right? Even if you're just looking at fertility treatments tonight and trying to work out if this is a pathway that we might go down and those types of things, you've probably already faced these challenges, right? So fertility treatments and that it is a challenge. And I think everybody here tonight will have already faced challenges along that road and shown some level of resilience, and so I guess trying to build up that resilience can help you cope with any challenges that come along in fertility treatment. And certainly counselling can help you to kind of set those expectations and help you support you along the way in that too. In terms of how you might build resilience, because I know, it's hard to think about that sometimes. I guess one of the first things is to think about filling up your fuel tank. I'll get you to move to the next slide. Really filling up your emotional fuel tank. Like you can't be resilient if you're out of fuel. And I think I see a lot of people who come into this and they're already kind of exhausted, exhausted by treatments or exhausted by all of the lead up to treatment and all of those sorts of things. So looking for ways that you can fill your, emotional fuel tank. And it's going to be different for different people. But, you've got to work out what works for you. What brings fuel into your tank? Spending time with friends or family, or not spending time with those people. Binge watching your favourite TV show, guided meditations, getting outdoors. I don't know, if you're a foodie, cooking something new, going to a nice restaurant, whatever it is that works for you. Important to keep your fuel tank up. You cannot have resilience if you don't have that fuel. I think another big thing is allowing some space for your emotions and reactions to news and challenges. We can often go into treatment feeling hopeful and excited, and I think that's completely normal. I think completely normal alongside that is to start to feel worry and anxiety, and so we have to allow ourselves some space to feel those things and not be too hard on yourself. Often people get stressed during treatment and they get stressed about being stressed and those sorts of things. So trying not to be hard on yourself. It's normal to feel these things in this time, and let's give ourselves some space to actually feel those things. And I guess another key one might be to think about keeping a balanced view of life. I think it's easier than you might think to get to a stage where you kind of expect bad news, right? And if you're someone here tonight who's been trying and you're thinking about starting treatment and those types of things, you can get to the point where you're expecting bad news and you sort of get filtered and can only see all the kind of negative aspects. So sometimes we find ourselves frightened of good news, frightened of joy because we're waiting for the other shoe to drop. And we're worried that those things are going to be taken away. So making an effort to practice gratitude, celebrate the small wins, the good moments, can slowly help to change that. And not having, fertility treatments as the sole focus of everything, trying to keep a balance up And I think that's my next point really, is around that. Keep up other life pursuits. You know, it can be hard if our identity as wanting to be a parent is being challenged so much through this. And so trying to keep up other life pursuits. So we've got those other parts of our identity, other parts of ourselves, such as work, your social circle, your fitness, your hobbies, all of those sorts of things, trying to keep up that balance. I think one of the biggest places that anxiety and worry and all of that can live is when we're thinking, ruminating over the past, and when we're thinking 10 steps into the future. So trying to gently keep yourself in the present moment, not thinking too much about the what if this happens and what if that happens and da da da. It can be overwhelming, right? So a mindfulness practice can help with this. And there's lots of apps available out there these days to help with mindfulness if that's something you're interested in. But otherwise, you know, turn to a hobby that engages you, something that really draws you in. You know, it might be looking back to the past in the hobbies and things you're interested in, but exercise, gardening, art, cooking, I don't know, music, all of those sorts of things can be really helpful to try and keep yourself in the present. A big one that I'm a big one on is enlisting a support network. You know, you do need support through this. So choose the right people and tell them what you need, you know. Some people in your life might give you support and make you feel good when you see them. You know, we've all probably got some drainers in our life that drain us of all life force. So let's stick with the people that are refueling our tanks. Tell us what you need from them. You know, if you're feeling too much pressure from your support work, give them fewer specifics. Don't tell them exactly when your treatment's happening and all of those sorts of things. You know, so think about it actively and try and enlist that support work in the best way that those people can help you. And use your professionals. You know, be informed, ask questions. Lisa was just talking about the nurse inquiry line there. You know, Monash IVF patients have got their fertility nurse, their counsellors, their fertility specialists, the scientists. They're all ready to help you. So make sure you kind of get the most out of them. All right. And I think all of those things together help build resilience. But, you know, if you are looking for support, there's lots of options out there. Obviously, at Monash IVF, support counselling, and that can be done, you know, in person, phone or Zoom, and it might differ between locations. We do have some support groups that, you know, we're offering. Again, it might be not always available in your location, but, you know, you could certainly ask about Monash IVF support groups. And, you know, there is always the option to look at external counsellors. So you can go to your GP and get a mental health care plan, and that will give you Medicare rebate access to psychologists as well. And I think the next slide too has some other support organisations that might be of help to you. And we've just finished building this mental health and wellbeing toolkit at Monash IVF in Victoria. It's got lots of, I guess, tips and strategies and ideas and things. You know, and if you are in need of support though, out of hours and those and weekends and that, if you are in need of urgent support, of course, there's always a lifeline, and the phone number for that is 131114. So 13 11 14 for lifeline. Thank you so much for listening. Yeah, I hope that's been helpful anyway. Certainly, you know, definitely touch base with your counselling service at the clinic if you'd like some more information. I'm going to be handing over to Dr. Gabrielle now, and she's going to be talking to you more about the fertility investigations that start. Thanks so much.
Great. Thanks, Claire. So I'm Gabrielle Desano. I'm a gynecologist fertility subspecialist in Sydney. I have been a consultant for almost 20 years, and training took about 10 years. So I've been doing this for a very long time. I'm going to talk to you today about investigations that might happen, particularly during your first consultation. I'm going to talk for, I don't know, 15 minutes maybe. An average first consultation is about an hour. So just to remind you that this isn't necessarily going to tell you everything, but just to give you a bit of an overview and I guess give you a bit of a headspace on what might happen when you come and see me or one of my colleagues. I'll just get you to go on to the next slide. Thanks. So when should you seek help? The sort of standard line, you know, the old panic at 35 one, is try for a bit longer if you are under 35 and check things out a bit earlier if you're over 35. This is obviously speaking to heterosexual couples, and there are lots of other situations where you'll know you'll need help. You know, you don't need to try. So in a heterosexual couple, if the woman is 35 or less, we generally say try on your own for about 12 months before you start to investigate, unless you think there's something going on or you know there's something going on. In women over 35, the actual chance of pregnancy per month is less. So in some ways, it would make more sense for us to say try for a bit longer. But what we really don't want to happen in couples where the woman's over 35 is for there to be something really simple that we can fix, and we don't identify it until she's 36 or 37. So that's why we say come in a bit earlier if you're older. It doesn't necessarily mean we move on and do anything or jump into treatment, but we particularly want to make sure we're not missing any kind of simply fixed or reversible problems. And then there's everyone else who should come and seek help or get advice whenever they know they need it. So there's obvious situations, women who don't get periods or who get periods very irregularly. There's almost certainly a problem with ovulation. Come and see us early. If you think you've got endometriosis because of pain symptoms or family history or whatever, you don't need to sit out this time. Various other medical reasons within heterosexual couples, and then if you know you need a donor, if you're a single woman, if you're a gay couple, if you know that you've gone through early menopause, there's a whole lot of reasons why you might already know that you're going to need a hand. Obviously just come and see us and we can talk through options early, and lay things out in a kind of relaxed timeline. All righty, next slide. Thank you. So fertility, what is a fertility health assessment? Basically, anyone who's hoping to conceive or trying to conceive should first see their GP and get checked out for all the regular preconception workout. And then a fertility health assessment is me taking your history, that's getting your story, examination, which is often as simple as a height and weight. We don't necessarily do anything more, but if there's any more information, an examination, looking at the tests you come in with, working out what extra tests you need, and then trying to compile that together to give you an understanding of whether there is probably a problem or if you're just kind of rolling the odds still, and where you are in that process, whether there's something that we can fix, something that we can get around, or whether we need to escalate or advise that you escalate into some kind of more complicated assisted conception. So I see a reasonable number of patients who don't want assisted conception, and that's fine, because reasonably often we can work things out without it, or we can at least outline what a realistic expectation should be for natural conception, and also talk a bit about what the treatments might be. And often it's not as frightening as people expect. Next slide, thanks. So at your initial fertility assessment, and it can be a bit of a mishmash. Some of this will be done by many GPs, but not always. We want anyone who's going to be involved there. So if you're a heterosexual couple, we want both of you. If you're a gay couple, we want both of you. If you are a single woman with a known donor, I like to meet you first, and then your donor separately, and then you together. So, but we need all parties involved. We'll take a history, and we've sort of got standard questions that we ask, but at the beginning I usually say, well, just tell me your story, because often that's where we get the big clues. We'll talk about lifestyle issues that you may or may not be aware of. Most people know that smoking's bad for them. It's really bad for reproduction. So big focus if you are smoking, to stop. If you're vaping, the answer is we just don't know, so stop. And go through all of the background checks, pap smear up to date, that kind of thing. Physical examination, generally it's just a height and weight. I don't do a pelvic examination on most women that I meet, because an ultrasound is usually more helpful for me. But if you pap smear or whatever, we can get that done. And it's not very common to need to examine a bloke, but if we need to, you know, we'll do that. We look at the investigations you've had, we work out the next investigations to do, and then we plan a date to regroup. And often in that first consultation, we'll kind of know what the plan is likely to be, but we'll wait for more information. Next slide, thanks. So what in that assessment might indicate potential fertility issues? A lot of the time it's obvious. If women aren't getting periods regularly, there's probably a problem with ovulation, and there's different reasons for that and different treatments for different reasons. If a woman's got really bad period pain, lots of pain with sex, it may well be endometriosis. Again, there's more investigations and then treatment option. If you know that you've had a chlamydia infection in the past and it took a while before it was detected, because it's a bit of a nasty bug, it's very quiet, especially in women, we know that you may have some tube damage, and so we'd be focusing quickly on that. And in blokes, if you know that as a kid you had an operation to bring your testes down when you were 4 or 5, that can be important. If you've got a history of having chemotherapy, it can all be, you know, there's some obvious ones. And then there's some subtle ones. You might have had a miscarriage, and when we're talking to you, it becomes clear that your periods are a bit lighter since the miscarriage. So then we start to be concerned that you might have some scarring in your uterus. So there are some subtle things that can come up in your story as well that might raise flags for your doctor. Next slide, thanks. And we'll just go straight. I'm going to go through the general investigations now, straight to the next slide. So as of late last year on Medicare, we're able to offer women carrier screening for the 3 most common genetic diseases that you can silently carry but pass on. Cystic fibrosis and spinal muscular atrophy are both recessive disorders. So they're things that you can have a good copy of the gene and a bad copy of the gene, doesn't matter. But if you both, as in whoever's going to provide the egg and the sperm, carry the same bad combination, an embryo or a baby can get a double hit of the bad one and be destined to have cystic fibrosis or SMA. And Fragile X syndrome is a more complicated one, but it's another one that a woman can carry silently and she can pass on. So Medicare now pays for women or screens women at no cost. And if she is positive, they will screen her reproductive partner. So we offer that, and we can offer a much more comprehensive screening that unfortunately you have to pay for, that screens for about 500 different conditions. In my job, I see lots of people who've had a baby and that baby's been born with a problem, and only through having that kid do they find out they both carry it. So, and their decision when they come to see me is usually that they'll do IVF and test embryos so that their next child doesn't have the same risk. And there's hundreds and hundreds of these things. So there's a whole lot of curveballs out there, and we can screen for those in a more comprehensive way, but that's an expensive process. For the screening, it's just a mouth swab and you send it to the lab, and then they send you the results. So it's very user-friendly. Next slide. And I should say the genetic carrier screening isn't about fertility. It's anyone who's thinking about having a baby. So then we investigate women. Different things that we're looking for. Generally, for me, most women who see me, I give them 1 blood test form and 1 ultrasound form. The ultrasound is to look to make sure their uterus is structurally normal. There's nothing going on inside the cavity that might stop an embryo implanting. So no polyp or benign overgrowth impacting the cavity that's actually quite simple to remove, that might be acting a bit like an IUD. Gives us an idea about whether there's any obvious endometriosis. So an ultrasound doesn't rule out endometriosis, but if you see it, you've almost certainly got it and it's probably bad. It tells us about your ovarian reserve. So the size of your ovaries, the number of follicles in your ovary. So we get a lot of information from a plain ultrasound, but it's important it's done at the right time of the cycle and by an experienced team. And so if you ring my rooms for an appointment, and you say I'm going to have an ultrasound, my team will check where you're going and where you are in your cycle. And if I order it, I'll write down when I want you to have it. I don't terribly often check whether tubes are open on a very first ultrasound, because the test hurts and it's expensive and it can cause an infection. But that's where we put, or the ultrasound doctors put a little tube inside your uterus and push fluid in and watch and see if it flows out the tube. It's not therapeutic, so it doesn't fix anything, but it can be diagnostic. So sometimes we'll do that, but not so often on a first scan. Usually a first scan is a plain internal scan. Some women can't tolerate that, and that's okay. We can do an abdominal scan, but it's not quite as accurate. The blood test form, basically it's any preconception screens that haven't been done, some endocrine screens, so checking various hormones, sometimes some genetic screens, and probably most informative for me, moving on to the next slide, thanks, is the AMH, which is this blood test to test ovarian reserve. So every month while you're in the reproductive phase, a batch of eggs is ready to go, one ovulates and all the others die off. As you get older, the batch gets smaller and eventually it gets to 0, and that's when a woman goes through menopause. AMH is basically telling us approximately how many eggs are there at the beginning of that process, as in that month, how many are ready to go. It doesn't tell us anything about your fertility, because as long as there's at least one ready to go, it will mature and ovulate. And if there's lots of them, it's not like the best one matures and ovulates, it's just a random one. But it gives us an idea of how long you've got left to conceive. So whether you're approaching menopause or you're running out of time in terms of ovarian reserve, it can give us hints as to whether your irregular cycles are likely due to polycystic ovarian syndrome or something else. And in our kind of therapeutic options, it gives me a really good idea how you'll respond to my IVF drugs if we get to IVF, so that I can titrate your dose as accurately as possible to get the best response, and also set your expectations on how many eggs I think we're going to get, more or less, so we can kind of work out, you know, how things are likely to go, and kind of get you ready for the ride. Next slide, thank you. Oh, there you go. That's everything I just said. Next slide. Sperm test. So we generally need a sperm test. Sperm test, we're looking at volume, we're looking at sperm concentration, motility, which is just how they're moving, morphology, which is how do they look, and then we'll generally check for antibodies. Occasionally blokes will make immune complexes against their own sperm that kind of cover the sperm up and make it hard for them to get into eggs. There's more complicated and more expensive semen analysis tests, looking for DNA fragmentation, and other factors that we sometimes come back to later, but rarely on an initial test. Men will also usually get a blood form from me as well. We check for a few infections and a couple of genetic issues on that blood test. So women will generally get one ultrasound form, one blood test form, blokes a sperm test form, a blood test form, and the carrier screening for the two of them. Next slide, thanks. Oh, keep going. So yeah, so look, seeing a fertility specialist doesn't mean you're having IVF, is probably the first thing I'd say. We're here to educate you as to what you should expect naturally at the moment, and whether what's happening to you is within normal or not. Work out if there's likely a problem, and if there is likely a problem, what it probably is. Try and fix it with simple remedies or things that we can just actually fix it, so that we don't get to know each other too well. And then if we think more complicated, invasive, sophisticated, however you want to put it, treatments necessary, give you a bit of an assessment of what's going to happen, but also what are your odds if we don't do anything, and what are your odds if we do that, and let you guys decide what you want to do. Next slide, thanks. This is a bit busy. When to proceed with IVF? So that's basically, as I said, most patients don't necessarily move on to IVF when they see us. Some we know straight away that's what they're going to need if they want to pursue treatment. Sometimes, you know, if we know sperm numbers are low and we can't fix it, if we know fallopian tubes are blocked or gone, so a woman might have had 2 ectopic pregnancies, one on each side, each time a tube was removed. Sometimes we know that's really where we're going straight to. Sometimes we're doing it for genetic issues where we know we want to screen embryos, or patients know they want to screen embryos, and so that's the only way we can do it. And sometimes it's a bit of a, well, I think your stats on your own are this, and I think your stats on your own with my help are this, and, you know, up to you. I think that's it. Next slide. Thanks. It's Tegan now, embryologist. Here she is.
Great. Hi, everyone. Hopefully you can hear me. So my name's Tegan. I'm an embryologist at our Cremorne lab here in Melbourne in Vic. And I'm just here tonight to talk about fertility treatments, specifically lab-based fertility treatments, so the different kind of technologies that we have in the lab. So I'm going to talk about some of the new technologies we have introduced, such as piezo-ICSI, which is a different type of sperm injection, as well as time-lapse incubators, which is something that we actually keep our embryos and help them to grow in. I'm also just going to touch on success rates a little bit as well, the success rates at Monash IVF. So firstly, what is the function of the IVF laboratory? What is my role and our role as scientists? So a number of things we do. This is a very brief summary of what we actually do, but we do retrieve eggs and we retrieve eggs and prepare eggs and sperm effectively, ensuring the correct technique is used to fertilize those eggs. So there's a number of different techniques we use. I'm going to go through a little bit later. We want to maximize the egg's potential. So we want to be able to create the best quality embryo as possible, because the better the embryo, the better the chance of implantation. We want to select the best embryos for transfer. We freeze surplus embryos. We also freeze eggs as well. It's part of our job in the lab. And we also perform embryo transfers, IUIs, which are intrauterine inseminations, and we do embryo biopsy. So we do take some cells from an embryo to send off for genetic testing. And then we would pick that embryo to the embryo that is chromosomally normal to transfer. And the one that I wanted to focus on today is the maximizing your egg's potential. So I just wanted to talk about specific things that we do in the lab to try and make sure that we get the best embryos possible. So this little diagram here is a picture of sort of what happens in the lab over that sort of 5 to 6 day period. So we do have a day 0, which actually isn't on here, but day 0 is your egg collection. And then each day, so we will inseminate the eggs, let them fertilize, and then each day we will check the embryos in the lab. And then on day 5 or day 6, we want what's called a blastocyst, which is this picture on the right-hand side. I will explain a little bit later what that is and what we're actually looking for there. But our aim is to create a beautiful blastocyst, ideally, and those are the ones that we want to transfer or freeze. And yeah, so some people call embryologists like the first babysitters, because we're the ones that are looking after your embryos from the very beginning. So yeah, it's kind of exciting what we do. We'll go to the next slide. So just a quick overview of sort of the very start of the process. So day 0 is our egg collection day. There's obviously a lot that goes on before this. So there's, you're chatting to counselors, you're obviously having the consultations with the doctors. We'll do some stimulation medication. So it's about, I think it's about 10 to 14 days of stimulation to stimulate those ovaries to collect as many eggs as we can. On egg collection day itself, this is all done under general anesthetic. So you would be asleep, you would not feel anything, but the clinician will access the ovaries through the vaginal wall using an ultrasound and will aspirate the follicles. So the follicles are inside the ovaries, they contain eggs. So they will aspirate those follicles. The liquid or the fluid that's in there will go into these test tubes that we as scientists will grab in the lab. We will tip them into dishes and just look at them under the microscope and try and look at the eggs. This picture over here on the very right-hand side is what we're expecting to see. When I'm training new embryologists, I normally say it looks a bit like a fried egg. So what you can see there is that the sort of the central part, which is what you would think is the yolk, is the egg itself. Those cells around the outside are called cumulus cells. So they are actually granulosa cells that help with oocyte or egg maturation. So it's important to sort of find those eggs. We need to learn how to identify them, because there's lots of other debris and blood clots and little other things that are in that fluid. So we want to be able to identify the eggs and then put them into our culture system. And then on this day, we'll also be preparing the sperm. So that will be happening sort of alongside it, and we'll be preparing both the eggs and the sperm for insemination. So we'll go to the next slide. Perfect. So insemination. So there's 2 main types of insemination that we do in the laboratory. The first one is standard insemination or standard IVF. So that's what happens when we get the eggs and the sperm and we just mix them together, and we let them fertilize naturally overnight. There are a few factors that sort of need to be met in order to do this. So we need to have sort of a minimum concentration of sperm to make sure that we have enough there. And they also need to be of good motility, so a good percentage motile and also forward progressive. And we also are looking at the morphology as well. So we want the sperm to be normal looking, so that there's a higher chance of that insemination to happen. The other type of insemination is called ICSI. So that's probably the one that you might have seen when you see like social media things or anything on the web about IVF, but it's when we inject a single sperm into the egg. We do these for patients when there's a male factor problem. So maybe the sperm doesn't have the right concentration, or if there's a history of poor fertilization with standard IVF. I think we do this in probably more than 50% of the IVF cases that we do. So it is very common and we do it quite often. And I wanted to talk a little about ICSI. So just to the next slide. Perfect. So this is, hopefully the video works. It's a little video of what ICSI is. So we've got the egg here on the left. We've got our injection needle with the sperm. You can see it at the very tip there. So the little circle at the top of this egg is called a polar body, and that's just a sign of maturity. So that just means this egg has the potential for fertilization, and you can see going into the egg, we are pulling up or aspirating that cytoplasm, and that just activates the egg for fertilization, and then depositing the sperm into the egg, and then just letting that one fertilize overnight. So as scientists, we will pick the best sperm, so morphologically normal looking, ideally progressively motile sperm to inject. And so we can see that really fertilization is going to happen. But once we've done that, we will leave them overnight in our culture systems, in our incubators, and let them fertilize. And then just the next slide. Perfect. So, so one of the new technologies that I wanted to mention tonight is something called piezo-ICSI. So this is a type of intracytoplasmic injection. It's more gentle and it's more of an elegant form of microinjection. It's quite new, so we've only offered it since we started a clinical trial with this in 2019, and it is more gentle. So we have a blunt needle that's guided into the egg by ultra-fast vibrating motion under light pressure. So it drills through that zona, which is the outer shell of the egg, before entering it. It's less traumatic than that sharp needle. We did do a clinical trial a few years ago, where for patients who consented to this, we put half of their eggs to the conventional ICSI, half of their eggs to the piezo, and just wanted to see whether we did have any different results. And we found that the piezo had higher fertilization rates compared to the conventional ICSI, and also decreased degeneration rates. I think we also found that on average, I think there was for patients they had an extra embryo utilized per cycle, which just means either an extra embryo for transfer or frozen, which is really great. And then just on the right-hand side, there's just some papers that some of my colleagues have published over the last few years about piezo-ICSI. So if you're interested, you can definitely go and check those out. But we're really proud of the results that we have so far with our piezo. And then, yes, this is a video of piezo. So hopefully it works. One of the main differences you can probably see with this technique is that the needle is actually blunt, so it doesn't have that sharp sort of thing to kind of pierce the egg. So the first step with piezo is we're actually we will sort of go through that zona, through the outer membrane, and then obviously put the needle in. And then instead of pulling up on that cytoplasm, there's like a pulse that happens, and that sort of relaxes the membrane and activates that egg, and then we're able to deposit the sperm in. So they do look kind of similar, but yeah, there are a few differences that just make the process a lot more gentle than that initial ICSI technique. So with piezo-ICSI as well, it's something that we would recommend for patients who have had poor outcomes with conventional ICSI. So that just means poor fertilization or high degeneration, or maybe poor blastocyst development or poor embryo development. So something to potentially chat to your fertility specialist about if you're interested in it. And it's something that's offered at many of our main clinics, not all clinics, but many of our main ones across the country do piezo. So the IVF lab. So after we've done that fertilization, what happens to those embryos? We put them into our culture systems, and we will culture the embryos for 5 or 6 days in order to hopefully make what's called a blastocyst. So embryos are very sensitive to changes in their environment, so we want to minimize the handling of them. If you think about it naturally, embryos are fertilized in the fallopian tubes, and then they travel down towards the uterus over that 5 or 6 day period. So they're not used, they don't normally see light. They're not normally exposed to any different temperatures to the besides the normal human body, so the normal sort of 37 degrees. We want to try and emulate that as much as we can in the laboratory. So these pictures are just some of our embryos that we see over those few days. And yes, what we're wanting to look at is that blastocyst, which is the last couple here. So all of our equipment's also alarmed in the lab. So we always have someone who's on call. Any incubator that goes higher than 37 or lower than 37, we'll get a call out and we'll make sure everything's fine. So it's obviously very important to make sure that these lab conditions are sort of kept as standard as possible. We also witness every single step. So if we have an embryo that we want to transfer, we have to move it from that culture dish to the transfer dish. There's always someone else who's witnessing to make sure that obviously all the names are exactly the same, and something that we take very seriously as well. We'll just head to the next slide. Perfect. So the other new technology that I wanted to talk about is time lapse. So we have these new incubators in many of our labs now that make it easier for us to sort of view those embryos and see how they go. So just to the next slide, sorry, thank you. This just goes through sort of what some of the incubators have seen over the course of IVF in general. This lady over here is Louise Brown. So she's actually the first IVF baby that was born, and she was born in the late 70s. So she's holding in her hand, I guess, well, maybe not exactly what she was grown in, but the kind of thing that she, as an embryo, would have been grown in. And then what we can see, obviously, there's been a lot going into technology over the last few decades. So there's another culture incubator from 2004 that was just this big box incubator that was just had carbon dioxide in a particular temperature. And now that says 2044, it's supposed to say 2024. We're obviously not in the future right now, but we have these incubators that are called time-lapse incubators. I'll show you a little video a little bit later, but some of the benefits to these incubators is that there's reduced handling, so we can actually watch a video of those embryos and we can go back in time and see how they were developing instead of just having to take them out of those planers or of those MIGs every day to have a look at them. So there's more monitoring. We can really see what's going on in those embryos. There's improved embryo selection, so we're able to really select the best embryo to transfer or to freeze as well. So I've mentioned a few times over this talk that we want to find, our ultimate goal is to get what's called a blastocyst. So this video here is what we would typically see inside an embryoscope. So you can see that the embryo it starts off at that 1 cell stage. It then starts dividing. So this is over, 5 or 6 days, and it divides into what's called a blastocyst. And at that stage, the embryo has divided into 2 different cell types. So we can see in the photo down the bottom as well, there's a big bunch of cells that's called the inner cell mass, and that's what goes on to form the baby. All the cells around the outside and down the back are called trophectoderm cells, and they go on to form the placenta and the placental supporting cells. So these are the embryos that we'd like to transfer and freeze. Not all embryos that fertilize will generally make it to this stage, but by trying to putting all these new technologies into the lab and selecting the best sperm to inject and things like that, we're hoping to create as many of these as possible. These are also what we use for genetic testing. So with the genetic testing, we actually take about 4 to 6 of those placental cells from the embryo. So we take them off and we biopsy them, and we send those cells off to our genetics team. And then we'll freeze the embryos. And then based on those results from the genetics, if an embryo comes back as chromosomally normal, then we would go ahead and transfer that. Or if it's not normal, then we would choose not to transfer that embryo. So that we find that we have better pregnancy results with our genetically tested embryos than we would with untested embryos. Right, on to the next slide. So I also just wanted to touch on our success rates. So it's difficult to talk about success rates across the country. Obviously, there's many, Monash IVF clinics all over Australia. So this slide is just going through our main 3 sites in Victoria. So we are really proud of our success rates, and we do consistently achieve higher than average outcomes. So this graph here is showing our pregnancy rate, which is our clinical pregnancy rate, I should say, per cycle across Victoria, compared to the national industry average. And it's just separated based on age. So you can see we have under 35s, 35 to 38, 39 to 42. And what we can see is that these, across these Victorian sites, we have higher clinical pregnancy rates than the national average across all of those age groups. So we will continue to invest in improving our success rates. And over the past 6 years, our rates have increased 8%, which just means that today we're delivering 8 more babies per 100 treatment cycles compared to 2018. So yeah, something that we're really proud of, and we will always be investing in new technologies and making sure that we have the best sort of technologies available to maximize our success rates and make sure that those pregnancy rates keep increasing and get the best for our patients. And yeah, that's it from me. Thank you for listening. And I think it's time for questions now.
Thanks for that, Tegan. Yes, so we have come to the Q&A portion of the evening. So we've had quite a few questions come through during the sessions. So we may not have time to get to all of them, but we will do our best. So Tegan, I might follow on from your presentation and ask you this first one, if that's okay. Who decides what process of fertilization the embryologist uses?
Right, yeah, so that's usually the clinician that makes that decision. And it's based on a number of things, generally the history of the patient, whether they have a normal semen analysis, whether they've come through before. In saying that, if, for example, if a patient was supposed to come through for that standard IVF insemination, and we as embryologists will prepare the sperm and they don't meet that minimum criteria, we may need to convert to the ICSI procedure, in which case we would liaise with the patient's clinician to do that. Yeah, but it's a decision generally with the patient and the clinician. So you can kind of chat to, and you can, if you say you want a specific one, they might be able to accommodate that, but they'll obviously try the best option for you. Yeah.
Perfect, thank you. Gabrielle, I might give you the next one. Can you please touch on PGT of embryos, rough costs, if you know them off the top of your head, and when you might suggest doing this?
Yep. So PGT is when we have, so if you remember the embryos that Tegan showed, the blastocysts, which were like a soccer ball of cells around the outside, which is the future placenta cells, and like a clump of cells in the middle of the inner cell mass, which are the future potential baby cells. That embryo hatches out of its shell, and we can cut a few cells off the embryo and take those cells away for analysis, and the embryo just kind of seals itself, and then we can freeze it. And so those cells that we take are from the embryo, so they genetically represent the embryo. Now, there's different types of PGT. Sometimes we're doing it for a diagnosis of a specific genetic problem. So that's called PGT-M, PGT-SR. There's different different codes. But if a couple both carry cystic fibrosis and they want to minimize the risk of having a baby with a double hit of the CF gene and therefore having CF, we can look for that in the embryo. The PGT that most people talk about is aneuploidy screening or chromosome screening. So that is trying to work out if the embryo has an extra or a missing chromosome or lots of differences in their chromosomes. And chromosome errors or differences in embryos are the most common reason why embryos just don't work, and the most common reason for miscarriage. And so we will often screen for them, particularly in patients where they've been recurrent miscarriage or related to their age. So that's kind of a rundown on that. It's not quite as fabulous as it sounds, though. So there are some pros and cons that we talk about, some pluses and minuses. The costing of it, if you're testing for a genetic problem, there's a workup fee, which Medicare covers. It's about $1,500 or so, but my understanding is Medicare covers that. And then when you do PGT, I've got my cheat sheet. There is a fee for biopsy, and there is a fee for testing. If you're doing it just for aneuploidy screening, so that is you don't have a genetic problem, you're doing it to minimize risk of miscarriage and failed transfers, then it's about just under $600 per embryo that you test. Okay, if you're doing it for a genetic condition, it's a slightly higher fee, but you get a Medicare rebate for part of that. Those fees are all on the website as well, and you can always ring up the finance guys at Monash for a better quote. I'm not very good at quoting. It can make sense financially, particularly for women who are older. If you're lucky enough to get lots of eggs and make beautiful embryos, if we know that you're 42 and we know that those embryos have 2/3 to 3/4 are going to be abnormal, it saves time and money and heartache and everything else to test. But it doesn't mean we always test. And not every embryo can be tested.
Perfect. Thanks so much for that. Claire, I might give this next question to you. The question is, I'm worried about telling my employer about my fertility treatment. Do you have any advice on how to approach these conversations?
Yeah, I talk to a lot of people about these concerns, that's for sure. And I think, for a lot of people, it really depends on the employer and their situation. Some people just really don't feel comfortable telling their employer anything. And so, I've often talked to patients about, how to get around that. Maybe just talk about the fact that you're having some procedures done and those types of things, so that you can at least give them some warning about the leave that you might need to take. Some people will refer to, generalized sort of women's issues and those types of things for these procedures, depending on your boss and that, because sometimes they will just then not ask any more questions. Having said that, it can be helpful to talk to your employers about this, because it does get a bit tiresome having to come up with different answers and reasons and questions and those sorts of things. And sometimes if it is comfortable in your workplace and you don't feel like there'll be any repercussions, it can make life a little bit easier when you're trying to schedule all these different appointments and things like that. I hope that's helpful for that person to think about. Some people will try it at the start not to tell their employer, and then they might find over time that they need to. It's very individualized.
Brilliant. Thanks for that, Claire. Gabrielle, sorry, there's quite a few that are probably targeted to you here, so I'll give you this next one.
Right.
Could you please speak a little more about women in their early to mid-30s who have been diagnosed with PCOS? What would the fertility process look like here? Perhaps in terms of some common challenges faced and potential treatment pathways.
So, this would take me an hour normally. So PCOS is polycystic ovarian syndrome. I see lots of women who have been told they've got PCOS who actually don't have PCOS. They have polycystic ovaries, which means they've got lots of follicles, but they're still ovulating regularly. So the first thing is that the polycystic ovaries is in itself not bad. It's polycystic ovaries that is associated with irregular or poor ovulation. That's what it reduces your chance of conceiving, because you just get less goes, and it's harder to know when you're going to ovulate. So with women diagnosed with PCOS, first of all, the first thing is to confirm the diagnosis, which we do through history and also various tests. The second thing is to try and work out if there's any lifestyle things that can improve ovulation. And sometimes there's quite simple things to do. And the common one is weight loss and exercise, but it can be quite extraordinary what even a 2 or 3 kilo weight loss can do in some women. So it can be really not necessarily a major hurdle. In some it is, but in others it can be actually quite a small adjustment. And then working out whether ovulation induction might be a good idea. So we've got great tablets that usually work that will make women who don't ovulate. And they make women who ovulate infrequently ovulate more frequently and with more predictability. So the most common ultimate treatment for PCOS, if lifestyle factors aren't appropriate or aren't working, is fairly simple ovulation induction. And for that, we generally track a cycle with blood tests and ultrasounds at least the first time, so you know that you're going to ovulate, when to have sex. And we try not to proceed with cycles where we think there's a high risk of creating a multiple pregnancy, which everyone who doesn't have a baby wants, but they're really dangerous. We really try for one at a time. So that's the very fast answer.
Thank you. Tegan, I might give you this one. With the results you have seen from piezo, is this the recommended process now?
Oh, that's a difficult question. It is still quite new. I wouldn't say it's necessarily recommended for all patients. Conventional ICSI is generally still quite a good option for a lot of patients. It's something that we are seeing a lot more of, though. I think it's also important to note that not all of the clinics offer piezo. So I know that most of the main ones in Melbourne, in Victoria, do. So like Cremorne, Clayton, and Geelong. And I know that they do in, I think, Repromed and Adelaide, as well as Sydney, Brisbane, and the Gold Coast. But any of those sort of satellite clinics, it is quite a specialized equipment, and also there's a special skill required to do that from the embryologist as well. At the moment, I think it's something to chat to your fertility specialist about. We only really recommend it for patients who have had that poor result with ICSI. So yeah, if they've had, poor fertilization or high degeneration or just poor blastocyst development, then we would recommend piezo. But I can see it's becoming a lot more common, and we are doing a lot more cases at the moment, based on, the good results that we're getting as well.
Brilliant, thank you. I might answer this next one. There's just a question here asking about costs and whether there are options for payment plans or if costs are always upfront. Certainly, if you do have any cost questions, the Nurse Inquiry team can most definitely help run through that with you. In terms of costs, there's a variety of different payment options. So we do offer instalment plans through our partnership with Zip Money. There's also options to apply for early access to superannuation to fund fertility treatment as well. If you're in New South Wales, there's a couple of different New South Wales government rebates that are available for IVF treatment and fertility testing too. So be happy to answer any other questions you have around costs. There's quite a lot of good information on our website. But yeah, if you want specific costs, happy to chat through your situation and give you some more, narrow it down for you. Can be quite mind-boggling when you're looking at all the different fees. So sometimes it's good to talk that through with someone over the phone. I'll just scroll through. We've had quite a few come in. Sorry, Gabrielle, I've got another one for you. Are there body weight limits for IVF?
Yeah, so that's an interesting question. So until very recently, the Royal College of Obstetrics and Gynecologists of Australia and New Zealand, so the guys that accredit me, the governing body, had a guideline that assisted conception shouldn't proceed with a female having a BMI over 35. That guideline quietly disappeared sometime in the last year. I'm not sure quite when. And so that's gone. Now, we know that the higher a woman's BMI, the higher the risk of any intervention we do and the higher risk of any pregnancy. So we really encourage women to try and bring their BMIs down towards a healthy range, but it's not always possible. And we also know that there are healthy pregnancies in bigger women. That obviously. There are BMI limits for the various day surgeries, and they differ between day surgeries for women who need an anaesthetic. So anaesthetics are more dangerous if your BMI is up, and depending on which day surgery your procedures are going to be, and the anaesthetists have different cutoffs. So we have different cutoffs at a couple of different day surgeries in Sydney. So sometimes I'll have a patient whose BMI is above our limit in the city, and they will have their egg retrieval at one of the other bigger facilities where the anaesthetists are comfortable going ahead. And then there's the blokes. The BMI of the blokes is important as well, because we know that sperm quality deteriorates with bigger men, and that we know that lifestyle changes can really improve that, both to improve the chance of natural conception, but also increase the odds of any assisted conception working. So it's a really difficult discussion, the whole BMI one, because it's not a punitive thing. It's really about safety and outcomes. Is what our focus is, but we're also aware of the time that weight loss takes, you're factoring in age of women and family plans and all of that. So it's a really complex and difficult discussion.
Thank you for that. Tegan, I might ask you this next one. Can a couple choose the gender of the embryo to be implanted?
So in Australia, gender selection is not legal. So no, no, not in Australia. We do the genetic testing, but as embryologists, we're only really told whether an embryo is chromosomally normal or not. So we personally don't even know really the gender. There is some cases that the gender can be found. So for specific gender genetic conditions that are X-linked or Y-linked, something like that, then they can, but it's only in very, very specific circumstances. I do know that a lot of other countries overseas do allow gender selection, but yeah, it's not something that we are really allowed to do in Australia. So yeah, technically no is the answer to that question.
Brilliant, thank you. Gabrielle, sorry, this is becoming a bit of an interrogation here. How common is it for there not to be a known reason for your infertility? And when this is the case, how soon would you recommend starting IVF?
Yeah, so it's really common. So it's about a third of, this is again heterosexual couples presumably having regular sex. It's about a third of the time we don't find a reason, and reasonably often we find a reason that we're not absolutely sure is the whole reason. Unexplained infertility is more common the older a woman is. So basically, your background odds are there, and there might be some unknown factor that halves or quarters your odds, and that doesn't really matter when you're 25 because you'll still be pregnant within about 6 months. But if that's going on at 35 to 40, it'll really spread things out. When do we treat based on that? It's more when we it's largely dependent on a woman's age, family plans, ovarian reserve testing, so how well we think things are going to go, how many kids I think they want, and a negotiation and crossover of when the risk benefit kind of tips in your favor. And so it depends, but often at about a year.
Perfect, thank you. Claire, I'll give you this next question. The question is, I have been considering starting fertility investigations, but worried it might be too much for my mental health. Can you give me any tips?
That's a good question. I think it's a good consideration that this person's making. I suppose it'd be one thing to think about your mental health and supporting your mental health, especially while you're going through fertility investigations. Dr. Gabrielle's talked about the types of tests and results and things like that, and there's lots of considerations to make. And I was talking earlier about having that resilience to face those challenges. So you really need to have that fuel tank a little bit full. And so that might mean addressing and having some of that mental health support while you're going through those fertility investigations. If you're looking for mental health support, maybe you've got it already, but you can go to your GP and ask to have a mental health care plan, and that will give you access to Medicare-rebated psych services. So that could be a good thing to enlist. And I often talk to patients about kind of get in front of the 8 ball with some of this stuff. Get onto your mental health and your resilience and start building that up whilst maybe you start those early investigations. I think Dr. Gabrielle also talked about the timelines in which you want to do that. So you don't want to leave this stuff too long in terms of those early investigations. And I think she's also given us a lot of hope for some of those early investigations and the treatments that are on offer that might not necessarily involve, IVF and those sorts of things too. So I guess probably trying to do the best in terms of filling up that fuel tank, getting that mental health support at the same time as doing those investigations, because we know there's a time factor to that as well. I hope that's helpful.
Thanks, Claire. There's a couple of questions with a similar theme. Just ask, sorry, I'll give this one to you again, Gabrielle. Just asking about supplements, and is there anything that people should be taking in the lead up to fertility treatment to kind of boost their success rates?
Yeah. So, my advice is don't smoke, minimal or no alcohol, eat your vegetables, take folic acid and iodine. And that's kind of it. So folic acid and iodine is the really small, cheap prenatal. They're the only 2 vitamins that have any evidence behind them that they change outcomes. I'm completely comfortable with women taking a prenatal multivitamin. They're more expensive, they're bigger. Some women can't swallow them. They constipate some women it gets side effects. So if no stress if you can't take those. No definite advantage. Yeah, they're probably good for you if your diet's rubbish, but if you're planning to take a prenatal multivitamin, you're probably looking after yourself. And that really is all I tell my patients. Now, there's a whole lot of other supplements out there, and there's a whole lot of other things with maybe these help, maybe these don't. DHEA, CoQ10, lysosome, there's melatonin, there's a whole lot of them. I'm not a believer in any of them. Some of them I'm comfortable for patients taking, some of them I'd prefer they wouldn't. But I think it's basically for women, I say try and tell your body you're a happy hunter-gatherer. So you're doing lots of gentle exercise, nothing too stressful because you don't want your body to think that it's dangerous out there and turn off ovulation. But make sure you're reasonably active. Make sure that you've got a good, healthy diet. And we all know what that is. Don't smoke, don't smoke, don't smoke. And don't vape now. Yeah. There's a huge market for you guys. There's a huge, you'll do anything. You'd stand on your head in the corner if I told you to for 3 weeks. And I think that there's a lot of supplements out there that are not necessarily taking advantage of that in a nasty way, but the reality is that you're a vulnerable group.
Perfect. Thanks so much. Thanks you, everyone, for joining us. We're going to leave it there. If you didn't have your question answered, it is really important to us that you get the information you need. So please be welcome to, we'll put up the QR code if you want to book in a complimentary chat with one of the fertility nurses. But yeah, thank you all so much for attending tonight. Good night.